I'm Dr. Karl Sieg from the University of Central Florida College of Medicine, and I'll be presenting for myself and my co-presenter Amina Malik on the Biomedical Chemistry update on pharmacotherapy for opioid use disorder. And I certainly appreciate the opportunity to be here with you all today. So opioids are extremely complex medication, and I would challenge you to find another class of medicines, even oncology medicines, that are more complex, perhaps some of the newer genetically based mechanisms, but they're very complex. If they were only just pain pills, it would be another situation. Even concepts like tolerance and physical dependence are more complex than at first glance. Withdrawal, hyperalgesia, how that all comes about, neurotoxicity under excitatory influences, and how that affects the mind and decision making of the individual, leading to addiction, especially those that are predisposed. There's a myriad of adverse effects ranging from addiction to irritability, other mental status changes like anxiety or depression, outright cognitive decline, constipation, disease of the mouth, endocrine disease, fall risk, sleep disturbance, fatigue, pain, hypersensitivity, increased accident risk, bone degeneration, sleep apnea. But what challenges us the most is the respiratory depression concern, which has taken a lot of individuals. Especially in the US, but I know in other areas around the world, this is a big problem. And I would imagine everybody in this presentation has either had a patient and or known somebody personally that has died of an opioid overdose. So one of the strongest approaches that's evidence-based to treat opioid addiction is medication-assisted treatment, otherwise known as MAT. MAT helps prevent relapse and helps the individual to make behavioral changes. I've seen this over many years of practice. These medications are most effective in improving mortality rates, reducing mortality episodes, and improving outcomes in treatment for the substance use related to opioids. It is only one element of treatment, as counseling is important as well as 12-step meetings and so forth. Agents for MAT include the antagonist, naltrexone and its derivatives, as well as agonists, methadone and buprenorphine. So we talk about naltrexone, which is an opioid antagonist, and it has a very high affinity for the mu opioid receptors. It can only be given once acute withdrawal has been completed because it's an antagonist. Standard dose is 50 milligrams a day, but it can be dosed every other day at a higher dose or every third day. I typically dose daily with the oral form. There's also an injectable, a monthly 380 milligram IM monthly injection that does increase adherence. You have to assess tolerability. I'd like to start with the oral first and make sure that it's tolerable. There are a few adverse effects, including headache, GI distress, hepatotoxicity, and skin reactions. If the patient has a persisting pain issue, it may be an issue because they can't stay on opioids, but there may be other non-opioid and non-medication treatment approaches that could be utilized. Benefits, well, over the agonist, the replacement therapy, there's no addiction or direct overdose risk, and there's less stigma if that's an issue. It certainly is in the US. It's effective in motivated groups for those in the criminal justice system and even impaired professionals such as physicians, greater than 80% abstinence at 18 months. So there's a lot more data in this respect, but it's really important to get past the third monthly dose if they're converted to the monthly injectable. The data shows getting past the third month really increases the odds as far as potential long-term adherence and recovery. Now, there are the agonists as well. Methadone has been long-standing in the U.S. It is regulated by very specific federal guidelines in our country. It's a long-acting mu agent, and certainly with the first successful medication used in conjunction with maintenance treatment. Buprenorphine is less regulated. It is a mixed mu agonist antagonist, and sometimes combined with naloxone. Sometimes cost can be a barrier for the combination. Agonist risks addiction in persons without a substance use history. So the guidelines really talk strongly about making sure that you established a substance dependence on opioids rather than just handing something out and creating an issue. So you don't want to exacerbate an existing addiction either. Could be relapse in a patient with stable remission. Maybe they're not on maintenance and they're already stable. So why go down this road? We have the eclectic approach where there's maintenance, complete abstinence, and sometimes harm reduction by reduction of the amount of use. That's less practical to the opioids. I think it either falls in maintenance or abstinence. Alcohol would be an example where it's more harm reduction. Also, diversion of the medication by patient, that can be a very serious problem. And certainly the agonists are potentially abusable. Methadone, highly regulated, as I've said. You have to understand dosing, and you really need to have experience with this medication before you start clinically using it. Otherwise, it's very easy to fall into a situation and the patient could die. Know that 30 to 40 milligrams will block withdrawal but not cravings. It's really higher doses that reduce opioid use, 80 to 100 milligrams. But that's not a dose you can start someone on. It would kill somebody that's opioid naive. Methadone is like a big wave out in the Pacific Ocean. It has a long half-life and relatively high oral bioavailability. Onset of action takes a while, a day or day and a half or so, 24 to 36 hours for opioid use disorders. But if you're going to use it for pain, which it's sometimes utilized that way, 6 to 8 hours, smaller doses as well. Methadone is a full mu receptor agonist. The studies show that it is more effective than buprenorphine, although more recent studies are showing them neck and neck. There's no ceiling effect, so if it's combined with other substances, there can be vulnerability to overdose risk. Not really any long-term damage. A few common adverse effects. The serious adverse effects: QT prolongation, so cardiac side effects over 120 milligrams daily, or if it's something involving drug interactions, overdose mortality increased with active liver disease and concomitant alcohol or sedative hypnotic use. So dosing toxicity, initial induction should not exceed 30 milligrams and go past 40 in the first day. Look at the bottom. One dose of 20 to 40 milligrams can kill a child. Repeated 30 to 40 milligram doses can kill an adult. One dose of 70 milligrams can kill an adult. Buprenorphine, which I'll cover here quickly, poor bioavailability. It's sublingual. It's a partial agonist, so the patient has to be they have to be off of the full opioid dose. Otherwise, if you give them buprenorphine, they'll go into withdrawal. Also know that it has kappa mechanisms that may involve some anti-addiction effects, as well as nociceptin receptor agonists that might involve effects on pain. Rapid onset, long duration. It's handled by the liver, 3A4. Watch for the drug interactions here as well. High affinity, no respiratory depression in the studies, but if you combine it with CNS depressants, you may get respiratory depression. So, and it's not a perfect world out there. So beware. Naloxone is there. It can help to reduce certain effects. It can make it a better agent, reduce the rush of buprenorphine if somebody gets that with buprenorphine. But pregnancy would be a concern here. Some common adverse effects, similar effects to full agonists, but usually no cognitive or psychomotor performance effects in most. How long? The data is not very good, but at least a couple years, and be practical about it. If it's helping the patient, you can run it longer. Patients may come off of it, but may have other events happen in their life that leave
Sorry to
them
interrupt you, Mr.
stressed. So now I will finish up. I've really talked about this. Naltrexone can be used also for alcohol, QT prolongation with methadone, uh, no naltrexone in pregnancy, and buprenorphine for pain effects.